Thank you very much. I'd like to invite the speakers and additional panelists to come to the front, and we'll now open the floor for questions and discussion. Joining the speakers in the panel are Dr. Kathy Ward. Dr. Ward is the Chief Nursing Officer at the Ronald Reagan UCLA Medical Center and holds the appointment of Clinical Professor
Thank you so much.
at the UCLA School of Nursing. She's responsible for nursing care in the inpatient and observation areas of the medical center, which is comprised of 24 nursing units, 455 licensed beds, and over 2,800 employees, including 1,900 registered nurses. Dr. Thomas Rosenthal is the Associate Vice Chancellor of the David Geffen School of Medicine at UCLA and the Chief Administrative Officer for the UCLA Health Hospitals. He is the co-director of the UCLA Center for World Health. He joined the faculty in 1986 and as Director of Renal Transplantation and started the renal transplantation program here. Dr. David Eisenman is an Associate Professor of Medicine in the Division of General Internal Medicine and Health Sciences Research in the UCLA School of Medicine and Community Health Sciences in the UCLA Fielding School of Public Health. He directs the UCLA Center for Public Health and Disasters and is the Preparedness Science Officer for the Los Angeles County Department of Public Health. And finally, Mr. Jeff Reed is the Director of the Office of Emergency Management of the Los Angeles County Chief Executive Office. He is responsible for coordinating disaster recovery efforts, developing emergency response plans, and delivering community preparedness outreach programs. So thank you all for joining us tonight. It's an esteemed and diverse panel representing the university, the county, and the non-governmental organization sector involved in response management. And thank you all for the wonderful presentations. So I'd like to invite you to raise your questions. I would appreciate it if you keep your questions short and so that we can get through as many in the audience as possible. So I'll take 3 questions and then we'll have the panel respond and then we'll take another 3 questions and move on from there. So who would like to start? Yes, please.
And I'm going to try to make it brief.
Could you introduce yourself, please?
I'm sorry?
Introduce yourself.
Oh, I'm sorry. Dr. Ricky Hendricks. I'm a gynecologist, microbiology in training, and I've spent time in Gabon. In fact, I was there.
Could you get to your question, please?
Oh, I'm sorry. It really adds because it...
Well, I can go ahead and take a step.
Yes,
Or
What is the ideal
So,
question, I think.
first off, my name is Margaret Aguirre. I'm with International Medical Corps, and I work closely with Nancy Ossie, our president and CEO. So I can speak a little bit about the situation on the ground where we are working. What we are seeing is, there needs to be a matching of both treatment units and the people, the qualified personnel to run them. We do not have that yet. We do not have enough treatment units, and we do not have enough personnel to actually work in them. There isn't really enough of any kind of personnel, whether it's cleaners, sprayers, burial teams, there isn't enough. And you can build treatment units, but if you don't have the people to staff them, then they will be empty. So ultimately, there needs to be a scaling up at a large level. We are not even really barely keeping pace with the outbreak, and so it continues to spread more rapidly than even, some of our early models. So, in terms of, we have to do both. We have to treat and we have to contain. We have to contact trace. We have to be able to reach out to the population, educate, spread the messages about that Ebola is real, that here are the ways that you can avoid it, that you need to not be near patients who are showing symptoms. So all those things need to happen. You can't just contain or just treat. You have to do both.
Who is responding besides yourselves? You built one treatment unit, you're trying to build another one. Who else is involved?
Right,
The
so-
U.S. Army is involved.
Absolutely. So International Medical Corps and I would say MSF are the only NGOs treating patients right now among the international NGOs. There's the Red Cross, and there are the ministries of health, the local health workers, who are Liberian, Sierra Leone health workers who are treating Ebola in the facilities, in the hospitals and treatment centers in Monrovia and other areas. But we are the only NGOs who are, international NGOs, who are treating patients.
So how much, what's the gap between what is being provided and what needs to be provided?
Right. Well, there aren't enough PPEs, so we have bought up the global supply of PPEs, essentially, and more need to be made because you have to have the right kind of PPE. There are a lot of companies that make them, but there are only a few that make them to our specifications. So you need the proper equipment, you need trained people. We conduct a 10-day training before people even show up to begin treating patients. They undergo a 10-day training. So finding enough people who can leave their hospitals and their universities to be able to go and spend 6 to 8 weeks over in West Africa is difficult to find. And so we're recruiting people heavily. We have vast networks of thousands of people, but for every several hundred you interview, maybe only a few are able to go.
Please.
I'm Perry Sachs. I'm an academic surgeon. I've done some work in Haiti. The question is, you have volunteers to take care of these patients in the ICU setting. What contingency plans do you have if they develop an acute abdomen or something that's going to require surgical intervention? And have you discussed with your medical staff their willingness to operate on a patient?
So I'm going to repeat the question for the video. So the question was, what contingency plans are available if somebody develops some other problem that might require surgical or other intervention?
You operate.
Well, it kind of depends what this clinical scenario is. If patients are highly infectious with Ebola, I think we make a decision basically, potentially not to expose additional staff and potentially patients to that situation. But it kind of depends on what's going on. I think that what you've seen at Emory and some other hospitals has been that they've had to go kind of and deal with the patient as the clinical issues came up. So, but in general, we are recommending that patients with confirmed Ebola not be transported out of the Ebola care unit at UCLA to undergo additional procedures. So they would not go to the operating room.
Would you potentially operate on a patient in the ICU, or would you ask your surgeons?
Well, I think we'd have to kind of determine what the situation was.
I think it's more likely than not that we would not operate on them. And we've had that conversation with our ethics committee. Had conversations intensively about that. And Kathy can elaborate on this as well in terms of if a patient is coding in the emergency department when they arrive, for example, and staff have not taken the half an hour to put the protective equipment on, they're instructed not to go to do the resuscitation. So this is a completely almost novel and unique ethical scenario where, unlike our normal training, which is rush into the fire, rush up the stairs to the World Trade Center, rush into the room to do whatever's necessary, here the instructions to staff are, you can't put the patient first if you don't put yourself first. And so, but that's a difficult thing, and we're trying to incorporate that into the training. So I'll be a little more direct than Zach is. He's trying to be diplomatic, but that patient's probably not going to get operated on.
Yes.
Jonathan Boxer, just a lawyer, right? My question is, can you talk about the medical merits or demerits of quarantine individuals who come from West Africa into the United States, as I think a couple of governors have instituted that procedure? And even if there aren't any medical demerits, is there some merit or medical merits to doing that? Is there some merit to doing it just to quash the fear factor in this country?
So the question is, what are the medical merits and demerits to quarantining? I suppose you could take the extreme case of somebody who's been to West Africa or been in a high endemic area or been a care provider. And what are the medical merits and demerits, and then what are I suppose, the political merits and demerits? Because ultimately, these kinds of policy questions are political answers, and it's the medical side of things plus the policy and legal side of things that also needs to be considered. But I think it's a good question.
Well, basically, a few governors in the United States have come up with, mandatory quarantine of people coming back from West Africa that are healthcare workers for the 21-day incubation period, and those are just a handful that have done that. I think there are no medical merits to that. I think that the medicine shows you quite clearly that you're really not infectious until you have a fever, and that what we're currently doing and what the Center for Disease Control and Prevention, Dr. Tom Frieden, what they've just posted recently is to do active monitoring of all people that are coming back from West Africa if they handle patients and have been wearing appropriate PPE or personal protective equipment, is that they get actively monitored twice a day for fever. So again, as soon as a person gets a fever, then they are starting to become infectious, and then they call their local health department or whatever their protocol is, and they get appropriately transferred to the hospital that is ready to take care of them. When you think back again about the situation in Dallas, that gentleman was living with a family for 4 days before he actually was hospitalized. He was sick, he had fever, even fever. He was sleeping in a bed with a woman whose sheets supposedly were soaked. Not one of his personal contacts came down with Ebola. The only people that did come down with Ebola were the 2 nurses that perhaps had, again, maybe because of not having the buddy system or for whatever reason, had some slight breaks in personal protective equipment. There were different stories that have passed around. But again, those people also were identified quite quickly, and they actually are currently now discharged from the hospital. So there are really no medical merits for it. I think the demerits are, number one, what she just said is that we need people to volunteer to work over there. And I personally have a friend right now that's in Liberia who's petrified that when she comes back for 21 days, she will be made to sit at home while she currently is the director of our, MDRO TB unit, and won't be able to perform her work here in LA County while she was volunteering so magnanimously overseas. So we're afraid that people will not choose to come up and volunteer. The other demerit is that perhaps people will lie when they get screened at these airport settings about their travel history. No, I wasn't a healthcare worker. I did something else. I just was visiting my uncle. I mean, it's like prohibition. I mean, you don't want to make people go into that area where they have to, come in the sneaky way or whatever. I mean, I think the more upfront people are, if you follow the science, it's going to work way better in the end and make sure that people cooperate with you rather than being afraid of you. And again, that's the big thing. Worried minds don't listen. So I think the main problem is that we have to be consistent as a nation, and that is a problem that actually was written about today, is that because of these inconsistencies, some states are recommending quarantine, others aren't. People wondering, well, is my state doing the right thing? So the science is one thing, but then people are wondering, well, why is Connecticut having a quarantine and we're not? Again, hopefully science will prevail, because I'm afraid that the merits of just doing the political answer really won't solve our problem. Ebola will continue, people won't go overseas to volunteer, and we'll still be faced with people coming into our country with potential exposures that they won't tell us about.
And I just want to thank please, definitely give her applause, because it's true, and I just want to point out that we are seeing people reluctant to volunteer because of these new restrictions. It's already happening. It's disincentivizing qualified people from doing the very thing we need them to do. If we're afraid of the outbreak, then the thing we need to do is allow people to go over there and stop it in its tracks.
How are donations?
Donations are better, but they're not nearly enough. We obviously, it costs us $1 million a month to run one ETU. So the U.S. government supported the building of our first ETU. That was $5 million to run it for a few months, but it's extraordinarily expensive.
Yes.
My name is Kelvin Garban. I work in the defense industry as a contractor. We had a conversation recently on base talking about the possible efficacy of using dry dock ships as medical facilities. even some of the things coming back from Afghanistan, those comics boxes were used in some of the different places. Is there any conversation like that going on?
So the question was, they had a conversation about the use of dry dock ships as medical facilities, and was wondering if that's happening within the relief world.
I don't know if anyone, I hear these discussions as well. I know it's something that's being discussed. I know that the U.S. military is looking at potential pods for its own people. So I know that that's a discussion that's going on.
Yeah, I believe there's a group in Washington. There's a group in Washington D.C. who are looking to take a decommissioned ship and turn it into a hospital ship.
Yeah, I was just going to say with that.
So the question is, what's being cited in the press in terms of mortality rates, and what the data are showing, and what's the difference in sort of where the rates actually fall? Yeah.
Well, and there have been, now this is the 20th Ebola outbreak, and there are differences in mortality by strain. And within the strain, for example, with the Ebola Zaire strain, this is, I think, the 10th outbreak that's happened, and there's a range of mortality rates associated. So the very first outbreak in DRC was approximately 90%, but none of the other outbreaks have actually reached that since that time. So I think that a lot of it has to do with the access to care. Exactly. It's access to care, how quickly people are able to respond to an outbreak. The outbreak in DRC that brought this 90% fatality rate to the forefront happened. It was the very first outbreak. Nobody knew what happened, and nobody even got on the ground until actually 226 people were already dead. So there were only maybe 5 or 6 people who were still infected when the first responders were actually out there and on site. So I think that this speaks to the importance of supportive care and the ability of rapid response to an outbreak, and that therefore you'll have differences in mortality just based on that. Yeah, it's averaged over all the outbreaks that have been recorded, which are very few, so until this point. No, it's when somebody says, yes, exactly. That's why they always say range, up to 90%.
And also just a comment, remember, these data are from Africa, where the data is not collected as elegantly as we do here in the United States. A lot of the deaths are underreported, a lot of the cases are underreported. I mean, really, this is just a ballpark figure, because again, the data is not collected very systematically, and the deaths are not always counted, or they're undercounted. So again, the 71% rate came out of the first 3,000 cases that were studied in the New England Journal of Medicine, but again, we're looking at thousands and thousands more cases that actually have yet to be studied. So when you look here in the developed country right now, we've not had any mortality among U.S. healthcare workers that have come in here. So our case fatality rate is 0. So again, it's varying, again, according to when people access care and when they actually get treatment. And we've heard about how infrequently people can have access to care in the affected countries with 1 doctor per 100,000 people or even less.
Absolutely.
Yes.
I actually have 3 questions. I'll make them really quick if I can. The first one is, I heard that there are Ebola receiving centers, such as all of you. Do you know what a realistic turnaround time is for them actually being transferred out? And then secondly, I've always seen a lot of suits being used, but we are actually using impermeable gowns. I just wanted your thought on that. And then lastly, screening. Now, I know the big question is about West Africa, when we're in triage. However, now that if you had contacts, maybe New York, Dallas, but a lot of triage nurses have brought up a very valid point is what countries are we really stopping at? And what areas are we really stopping at? Because if they slip through the cracks. That's just screening. And then also I know you mentioned about fever. I mean, if I take a Tylenol, then my fever is going to go down, right? Is it not responsive to Tylenol? Or that's my question, because if they're coming in and they don't have a fever because they took Tylenol, well, they're still infectious. So it's just more of a learning standpoint. So those are my 3 complicated questions.
I'll answer two really quickly. Number one, there are more than the one hospital. First of all, the hospital that you mentioned is not necessarily a designated hospital, and we do have a list of designated hospitals where we are working with actively training with them. UCLA is one of them. I think the California Health Association yesterday mentioned other hospitals that are on our designated list, although we do expect every hospital to have those screening questions. And you're right, the basic questions are not so much maybe the 3 countries that we're looking at, but also, have you had contact with an Ebola patient? Not did you come from New York, not did you come from Dallas, but when you were in New York, did you have contact with the patient? That's the important question. We don't care about you being in New York or or seeing people from West Africa, but did you actually have physical contact, come in contact with bodily secretions of a person that had Ebola? And the countries could change, the locations could change. So that's number one. So number one, those are the questions that you want to ask. Number two, fever doesn't always have to be there. You're right, people can take Tylenol, but if someone's coming from an affected country and is taking Tylenol for their fever, they're also going to be having other symptoms that I'm sure Zach could go into that are going to make you worried. So I mean, again, if someone comes from one of the 3 countries, you're still to call the health department whether they have fever or not, because we actively follow those people even if they have no symptoms at all. And the rest of your questions, I think, had some clinical implications. Like, what's the turnaround time? What was the turnaround time question? Like from
Turnaround time, our protocol right now, we're saying about 2 to 4 hours. I would love to know where we can get that designated list.
We're not giving that list out. What you do is if you think you have a patient, you call 213-240-7941. There's a doctor, that should be plastered in your memory, tattooed on your arm. There's a doctor in the public health department on call 24/7. Once we get that comment that you think you have an Ebola suspect, first of all, we will help you triage that patient. If it really looks like a true suspect, we will arrange for transfer with EMS to take it to one of the hospitals that are designated to be a hospital that can appropriately treat for that patient. But again, you are responsible for isolating that patient, making sure you protect yourself, make sure you treat the patient as well.
Dr. Ward?
Yeah, I was going to say that what's important about your screening process is not only that you ask the questions about which countries, but that you have a process for notification. So we ask all patients in the ED and on admission about their travel history, but then our process is to call our infectious disease doctors, who will then contact the county for us. So you should have a procedure written up for all your triage nurses so that they know exactly what to do, whether it's in the ED or your ambulatory areas.
Yes.
Is there talk about recruiting Ebola survivors as healthcare workers since they're not immune?
Question is, what about recruiting Ebola survivors as healthcare workers, since they're now immune?
Well, that actually has been done in the past in all of the previous outbreaks, that when, I know this light is very bright. But in previous outbreaks, that has happened, and it's been very easy to do so because previous outbreaks have happened in very isolated areas. So you have kind of a pool of people that are there and directly implicated. I don't know what's going on in West Africa, but it seems like a very reasonable strategy.
Yeah, it seems like a great idea, and I can't answer that question because I don't know if that's under discussion.
Should be.
Yes. Yes, please, yeah.
Hi, my name is Jennifer. I actually just recently graduated with my master's in global health, and I'm really nascent in the field. But something that I've noticed is definitely how the media is portraying it and the effects of that, especially when we have similar situations with autism and anti-vaccination. So I was wondering what you all would say, because I'd rather get my information from a panel like this than some of the news outlets. So what would you say about how the media portrays it?
So the comment question is, what about how the media is portraying this and how they portray other sort of health issues that might be somewhat controversial or settled in the medical world, but controversial in the public world?
You know, if it bleeds, it leads. They don't want to hear the stories that say, don't worry. I mean, we get interviewed all the time, and I'm sure every one of us have gotten interviewed, and anytime you give a calming word or, this is what we're doing to be proactive, they take out, like we actually against my will, put out a piece of paper that said the difference between the flu and Ebola, just so people wouldn't start getting worried, because flu season is coming, as is norovirus season, and people are going to be getting sick, and we're just worried. And because of that, even though we were trying to be actually very accurate in saying you're not going to have Ebola when you have A, B, and C, because you probably have the flu or something, some news writer said Ebola and the flu are the same. You know, so I mean, even though you can try and say something in one way, the media is going to try and project it in some way to sell newspapers and actually to create some unrest.
I've actually had some very positive experiences with the media doing. In fact, today I got a call from a Wall Street Journal a guy who was wanting to fact check and was asking me questions. And you know, I think it really depends. And I think what's ending up happening is that the very good, reliable news sources like New York Times, Wall Street Journal, LA Times, Newsweek, Time Magazine,
PBS.
All of these, they're actually being very responsible, I think, in their coverage of this and trying to help assuage some of this hysteria that's been, you know, rife amongst the U.S. population right now. But I think that all of us as public health professionals have probably taken it upon ourselves to be informing our own communities. And at the School of Public Health, we're actually going to be starting a campaign using social media networks to try and get people to put out appropriate information, and I think that the students and the faculty will be really interested in being able to do that, and just in their own networks make sure to circulate information that's correct. And so I mean, but I really do think that the right media sources have been very good about it.
Well, and I would say there seems to be, having been a former long-time journalist, there seems to be a real distinction between print and broadcast media. And having dealt with all of them, literally every one of them, on this crisis, I've noticed a really stark difference between the TV and the print people. It really was noticeable with this. I think that the beast that needs to be fed daily and hourly on television, this disease does not lend itself to black and white conclusions, as is often the case. I think the New York Times has been profiling us for 3 weeks now, doing a series about our work. And so, of course, I think they've been extraordinary.
Are you saying CNN did not distinguish themselves?
I'm not going to call out any names, except for if we can't say something good. But I do think a lot of the print outlets have been really responsible and really trying to work hard at getting it right.
I'll add that I think if you want to, on social media, there's some excellent sources out there. And on Twitter, for instance, you can find some great, I think some of the best information is coming through on Twitter. From the microbiologists, from some of the reporters like Laurie Garrett. I would suggest following them for breaking research articles. I mean, they've been fronting Lancet articles, other virology articles that were published, they front them within hours of their being published. I wouldn't necessarily see as an internist. So I would suggest there are lots of good sources out there.
Is there any scientific evidence that this is somehow a more virulent strain, more pathogenic?
I can only say what I've read, and I did read that Peter Jarling, who's the head of the Integrated Research Facility at NIH, noted that the viral loads were higher than they had seen in previous outbreaks, but that there could be a variety of different reasons for this, and so it's unclear. But it would stand to reason. I mean, every strain is different because it jumps from an animal into a human population and moves over time. So it's possible that it could be. Just like a flu might be more virulent this year than last year, et cetera, et cetera. So it stands to reason.
And the fact that there's an animal reservoir suggests that this will be with us for some time to come, because that reservoir is always there to harbor.
Well, I think that actually brings up the point that I keep trying to make with anything that I'm doing, which is that this is not the first Ebola outbreak and this is not the last. And I think that with the appropriate resources, that sooner or later we will get this under control. I think I'm optimistic that will happen. But the point is that this is going to happen again, and that you need to have the kind of public health preparedness that hasn't been in existence in these countries. And I think that we all are beginning to understand now that it doesn't, we can be prepared here, but if we're not prepared in these other countries and don't help them become prepared, then it's going to be our problem sooner or later.
So I would like to take one more question. I'll take two more questions. Please go ahead.
Okay. Hi, I'm Peter Trout. I'm a medical student, and I've actually worked in 3 of the countries where Ebola is rampaging. And my understanding is that fear and distrust has really hindered some of the efforts to contain things on the ground in West Africa. In that light, what would be your recommendations to us as we leave this building, as we talk with friends, family, coworkers, whomever, to try to quell fear and distrust of the efforts that you all are doing here?
So the question was, fear is rampant, maybe hindering the efforts in West Africa. It certainly is rampant here in the United States and maybe leading to decisions that are not necessary and may have deterrent effects. What would you advise to the folks in this audience tonight as they leave the building? What message should they give out?
I think that you should tell your, social networks that you're getting great information on what's really going on, and that people shouldn't let fear dictate actions that could have unintended consequences. I mean, people should get informed. They can't just spew what they're hearing as hearsay. They should get informed. So I would urge people to follow UCLA or International Medical Corps on Facebook and Twitter. And Lori Garrett's a great one. I mean, they can get information. They don't need
to look for good news sources, reliable ones.
I'm sorry?
I have a follow-up on the adequate response question.
Okay.
So just real quick, there's an article a few days ago in Lancet Infectious Diseases, where they did a study of the dynamics of the disease in Montserrat County in Liberia, and their conclusion was that if nothing is done, current policies are going to lead to a catastrophic death toll.
Yes.
And they said that, how to go, the number of beds at EBD treatment centers needed to effectively control EBD in Montserrat County substantially exceeds the 1,700 pledged by the USA to West Africa total. So this is what they're saying, that all of the total effort of the U.S. would not even be adequate in one county. Can we, he's discussing more like what that gentleman discussed about, like a, U.S. military, Russian military, Chinese military response, like on an emergency level to really solve this problem and avert what they call, Lancet just called a catastrophic, death toll.
So your point is a very important one, and that is that for reasons that are a little hard to comprehend, the response is underwhelming.
Yes.
Well, that's what Lancet Infectious Diseases published based on a study that they did in one of the main counties where it's, where it's...
Whereas if the response was more vigorous, containment would be possible.
Well, yeah, I'm saying that we have to. And what they're saying is that the total response of the U.S. at this point is totally inadequate in one county. So can we think of like a much bigger picture, like like people were talking about here in terms of hospital shifts maybe. We have biowarfare. I'm not saying Ebola has anything to do with biowarfare, but the military has biowarfare capabilities to deal with highly infectious diseases.
Well, I will say that the U.S. government has been pretty, has come out pretty strong and has proved to be a leader so far on this. No other government, no other country has stepped forward in the way that we have. Cuba's a good one. It's a good example.
France.
I think that there has been some good response, but of course it needs to be more. And it is underwhelming, and other governments need to step forward as well. I mean, we made our commitment, the U.S. made its commitment to Liberia, but Guinea and Sierra Leone have their own issues, and they can't be forgotten either, so.
And this is a place where I would fault the U.S. media, that the enormity of the problem and the necessary response is not being properly profiled. It's all about Dallas, New York, the nurse in New Jersey now. And, it's okay to cover that, but we're not hearing about the enormity of the response.
Can we get the panel to give President Obama a grade on how he's responded to this epidemic?
No. No, we won't go there. Yes.
Isn't the fact that you're minimizing and underplaying the seriousness of the disease to calm people down actually contributing to the lack of urgent response from governments.
Oh, I don't
In
think
the
any,
case of AIDS,
I don't think anyone is saying that this isn't a disease to worry
in the
about.
beginning with AIDS, they said you could only get it by needles and gay sex. And a few years later, they had to change everything. Millions of people died. And this is what we're facing right now. This is a disease of poverty.
Yes.
We should be having airdrops of food, Gatorade, these kinds of things. So I think it's a disservice to say, we're going to be okay, we're prepared, it's not that bad. And you have this incredible situation in Africa that can come very quickly from the Caribbean to the United States, as the head of the U.S. Military Command, Southern Command General Kelly has said. And I think underplaying it without a little bit of panic gives people a sense of complacency when we should be beating down the doors of the Obama administration to show leadership. Like little Cuba, with 11 million people, has sent 461 doctors already.
So, you make a very interesting point.
Mutations. These assurances do not address the question of mutations. You can't say certain things for sure because there's a lot you don't know about this disease, similarly with AIDS in the 1980s.
Can we talk
I've
about
heard
like
the
the
data about there
mutation?
being no symptoms. I mean, when you're not symptomatic, that you don't have any viral
Yeah,
shedding.
how do
I mean,
you know
are those
that?
studies there? We say that all the time, and I hear it said over and over again,
How do you
keep
know
coming
that?
down. But are those studies there?
So
It
let
could be
me-
in French journals, but do we see them?
Let me ask the panel to comment on two things. Studies about viral shedding and studies about mutation.
In vivo. I mean, we then the human beings.
No studies on mutation.
Anybody want to talk about it? Yeah.
Anybody care to respond?
I'd be happy to talk about it.
Maybe
Well,
somebody that knows.
okay, well, I can talk a little bit about mutation. So of the 23 known viruses that are considered to be very serious to man, none of them have ever mutated to change how they infect people. And that's very important to remember. Now, it is theoretically possible that Ebola could mutate to change, but it's unlikely. And normally when you have a mutation, one thing, there's a trade-off. You know, something may become more easily spread, but may become less virulent.
Mm-hmm.
It's not just that something's going to happen. It's going to become, much more serious. It could mutate and become much less serious.
That's not true. That's not true.
Sir,
I'm sorry.
this is not a debate.
Sir, I'm sorry. I apologize. But that's not a true statement.
This is not a debate.
Never
Sir,
mutated to respiratory.
sir, this is not a debate.
And just to reiterate, this virus has been known since 1976. It has been studied in many, many other outbreaks. And again, it has not been shown to mutate to be aerosolized. It is still a contact-transmitted disease. I think that, yes, we don't have the viremia data that you would like to see daily. I think that data, now that we actually have people that have been infected in the developed country, we will be getting that data from people that have developed the disease here in the U.S. If anything, they'll probably be contributing to our pile of information about when you're viremic, when you're symptomatic, and when you're infectious. Now, the other thing you have to remember, you have to go back and look to see what other diseases were like. Remember SARS. SARS, you were not infectious till your second week of illness. So even though you got the virus right away, you did not pass it on most likely until you were hospitalized and very infectious. And that was very good because we were able to quarantine people when they first got diagnosed, and then they did not spread the disease. So again, there are other examples that show just because you're infectious, just because you're infected doesn't mean that you're infectious. So again, we have anecdotal stories about people that were sick but not that infectious, so their viral load obviously was not that great to transmit disease, but we don't have true studies that have looked at it in vivo, but those studies will be coming forth. I think in all the other outbreaks that we've seen in the developing country, we've not seen casual transmission. So again, we've not seen casual transmission here in the U.S. of the few cases that we've had. So we just have to postulate to what we know and not go to what we don't know. Because you can always hypothesize the what-if scenario up until, forever, but that what-if is yet to happen. So again, let's stick with what we know and deal with that before we go on to postulate about things that have yet not been proven.
And that's very good, thank you. We're getting toward the end of the session. I'd like to perhaps ask the panelists if you have any final words for the audience. Anne, I'm going to put you on the spot and start with you.
Well, I mean, I just think that it's very important to reiterate the importance of getting good information and transmitting good information forward. I mean, I think that this issue of fear, making it very difficult to be able to interpret what's going on, has become very problematic in this outbreak. And so I think just the one thing that is, you asked, well, what do we do now? And I think the thing is that what you do is you tell people to look to good news sources and to take with a grain of salt some of the hysteria that has been put forward. And so to me, that is the most important thing to take from it. I think most people are here because they're interested in getting information. It's a good first step.
Zach?
Just to reinforce a lot of what's been said already, I mean, my job is obviously, I work for UCLA. My job is to make sure that we're ready here at UCLA, and we've expended resources to do that. But I think you need to understand that the best way of protecting our local population is by, treating Africans and decreasing Ebola in Africa. And that's really the best way to protect ourselves here in the United States.
Can we just ask one more question? Could we ask?
No, ma'am. I'm having the panel give the final responses. You'll have a chance to talk to the panelists afterwards.
Mr. Jeff, we can tell us what his department does. You talk from a very important department.
That's what we're going to get to.
We're going to get to him, yes. Yes, we will get to him.
Ma'am, I'll be happy to talk to you after.
And basically, I too would just like to say, again, we always worry about what we don't know about, and we worry about things over there. But I think most of the population in this room is more likely to die because they're texting while driving, because they're overweight, because they're drinking too much, because they don't exercise enough, because they don't eat healthily. So again, let's control what we can control in our lives. Let's work on trying to control what we can control through other mechanisms, through collaboration and coordination. But I think worrying about what we can control is not going to help us. Let's take charge of what we can control in our lives.
We can control who our government leaders are.
Go vote, November 4th. Do it. Yes.
Know who you're voting for.
I just wanted to comment lastly on what the fine woman said, because I agreed with a lot of what you said, that, trying to balance fear in this country that is hindering us from doing the right things with really understanding the enormity of the problem. We are facing potentially millions of people who could die, and that's serious, and we have to do something, and we must scale up. I completely agree with everything you say. But at the same time, we can't have people so afraid that they kind of throw the baby out with the bathwater. So,
Dr. Rosenthal.
I'm only here to support Dr. Rubin and to work collaboratively with the county to assure that UCLA is ready to care for anybody that in fact might be a potential patient, and assure that we do that safely in Los Angeles.
thank you.
Dr. Ward.
I'd like to say thank you for having these kinds of forums and for you all to coming out to these kinds of forums, because it is important that we learn as much as we can about this virus. And all of the nurses at UCLA have all the same questions that you do. They want to know, are they going to be safe? When the nurses in Dallas got this virus, that was a game changer, I think, for the country. And so, and yet they are nurses and they want to take care of these patients because that's what we do. So our job is to get all the facts we can, to learn as much as we can about it, just like you all are doing here tonight, and then to say, we are going to be as prepared as we possibly can and to get through this together. Our managers are putting on the suits and going in the patient's room. Dr. Rubin and Dr. Uslan, our infectious disease specialist, they're putting on the suits themselves and going into these patients' rooms. They're prepared to do that. So as healthcare workers, that is what we face every day. And the hospital in Dallas, really got a bad rap, but they did everything that they could by the CDC guidelines. And patients are calling up to that hospital saying, oh, I don't want to go there because you had Ebola. But now we know that's really an unfounded fear. And so we are facing that same thing at UCLA. Patients are calling up, should I still come in for my hip replacement? Yes, you should. So there's a balance of the fear that we're trying to manage, and I think it's really helpful. There are things we don't know, and yes, there's a lot of anxiety about it, but the more you know, the better prepared you'll be. So thank you all for coming.
Dr. Eisenhower.
It's your soapbox now, as they say on left, right, and center. I'm going to make a plug for trust, because that's what I hear in a lot of the questions today, and I think it's at the heart of why we're here today. We had problems with trust in this country last week. We had problems with the CDC. They made some missteps. But I think we do trust, a lot of us in the healthcare system, though we criticized the CDC early on for making some mistakes, we did that in the spirit of peer criticism. And actually, the CDC has done fantastic work in quickly, rapidly responding on a lot of levels, both to protect healthcare workers as well as to protect the public. Tom Frieden is one of the great public health officials of our country. So I think we need to know that we can trust the CDC. We know that we can trust UCLA. We know we can trust the Department of Public Health. And it's these kinds of events where we can talk honestly and be transparent and air all these things that's going to create an atmosphere of trust in all our communities. So this is really a plug for trust.
Thank you. And Mr. Reeve, I'm sorry we haven't heard from you yet.
That's okay. I wanted to echo the sentiment about each of you being an ambassador for the truth and for the science, and to encourage you to share that through your networks so that voice and message can multiply and spread and be a balance against some of the unreasonable messaging that's out there based on fear. And then one of the good doctors I work with was asked about, are we prepared? And I can tell you that I work on a task force of over 15 county departments and partner agencies, and we are focused very, very intensely on being prepared. And we are prepared. We're more prepared today than we were yesterday, and we're going to be more prepared tomorrow. And so I want to reassure you that the professional and emergency management and public safety and health communities are working very, very cooperatively and very earnestly on meeting this challenge. And we will meet the challenge, and we will ensure the public safety. So with that, I'll say goodnight.
On that note, I would really like to thank the panelists for a very good discussion and very good presentations, and thank the audience for coming out tonight. As we know, there are a variety of points of view, but I think we have to trust and move forward and do the best we can. Thank you very much.